Welcome, everybody. I imagine some people will continue to join us, but welcome to the Head and Neck Cancer Survivorship webinar series developed by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session today is on oral health for oral and head and neck cancer survivors. I'm Michael Moore. I'm a head and neck surgeon in Indianapolis at IU Health. I also serve as the president of the board of the Head and Neck Cancer Alliance. We're lucky to be joined today by Dr. Joel Epstein and Carolyn Dee, who will be our presenters for the webinar. For those of you who have not been involved in these before, I'll just give you a little outline of the session. So I'll start with just some brief introductions of our panelists, and then we'll hear from Dr. Epstein on the impact of head and neck cancer treatment on oral health. This will then be followed by Carolyn walking us through her journey with her treatment for her oral cancer and give us her perspective on what it means to be an oral cancer survivor and some of what she experienced along the way and what she did during and it has to do after her therapy to maintain her oral health. So again, thank you to both of you for joining us. Just want to give some brief introductions here. Dr. Joel Epstein is a diplomat of the American Board of Oral Medicine. He works as a consulting staff member in the Division of Otolaryngology, Head and Neck Surgery at the City of Hope in Duarte, California. And he's also on staff at the Samuel Alshin Comprehensive Cancer Institute at Cedars-Sinai in Los Angeles. He was a former president of the American Board of Oral Medicine. I've had the good fortune to get to know him as a fellow board member of the Head and Neck Cancer Alliance. He's always really a trusted expert for me whenever I have a question related to oral health and dental issues related to head and neck cancer treatment. He conducts a private practice in California in oral medicine. He's published extensively in the field in both oncology, infectious disease, facial pain and symptom management in oral medicine. And he has over 750 publications in the form of either papers, abstracts, textbooks, or book chapters. We're also fortunate to be joined by somebody I would like to consider a friend, Carolyn Dee, who is from Truckee, California, but is in the process of relocating to Idaho. So thank you so much, Carolyn, for joining us during this interesting time. Carolyn is the former mayor of Truckee, California, and was diagnosed in early 2018 with squamous cell carcinoma of the oral tongue. And I met her during that time. And I'll let her walk you through her cancer journey ahead in the session, but when we came up with this topic, really to me, she immediately came to mind as somebody who would be an outstanding person to be involved in it. Not only has she been through surgery for her oral cancer and also adjuvant radiation therapy to follow, but and she really could talk us through what that means as far as the impact it has on your oral health. But also, she's a great example of somebody who, through her own perseverance and hard work, has really come out on the other side of it with excellent function and a remarkable spirit. So I really appreciate her taking the time to join us with this today. She, again, is in the process of making the move. So thank you so much for taking the time. Absolutely. So I think just without further ado, I'm going to lead into the presentation by Dr. Joel Epstein on the impact of head and neck cancer treatment on oral health. Thank you, Dr. Epstein.
Yeah. Well, thank you, Mike. And I also want to, before she presents, thank Carolyn for being here. We really are looking for spirit and functionality, and that's really, I guess, the description of outcomes we would like to see. Just going to the slides. And so I'm starting off as someone who has been involved in oral care in the oncology world for some time. I'm very happy to be actively involved with the Head and Neck Cancer Alliance and the American Head and Neck Society, as well as the dental organizations that I'm part of. So we're really talking about survivors. I should mention also that there are a lot of attendees that signed up, so I think there seems to be an interest and maybe a need for this kind of talk and shared presentation. I understand it's in the range of 400 attendees, which is, I think, a large Zoom meeting and a large meeting in any measure. We're also going to, throughout the brief slide presentation, have some participant polls that you can participate in that relate to specific questions. There will be 3 of these that will allow some participation and a summary that we can give you after each poll is run. Oral care in oncology really precedes even the diagnosis as far as the dental world is concerned, and that is an early identification and recognition of the condition that ultimately may lead to diagnosis and then referral for cancer treatment. Once diagnosed, the role of the dental community continues, and it's really from start to finish throughout survivorship and during care in some cases directly for the cancer. So the standard of care prior to head and neck cancer treatment is to have a complete and comprehensive oral dental examination. And the goal of that is to identify conditions that are of dental origin that may become issues during or following cancer therapies for head and neck, and also to stabilize any conditions that may be present, and then also to initiate preventive interventions to reduce some of the complications that may follow in survivorship. That is really the focus of today's program. The dental provider needs to be aware of and understand the nature of the cancer diagnosis, have a general understanding about the cancer therapy that will follow with respect to the site of the lesion, for example, where the radiation treatment plan may go, whether there's additional medications that will be used, and to understand the probable outcomes. And this is always best in an integrated team of dental participant provider, as well as the oncology and or cancer centers. So one of the themes that I will come back to in a couple other summary statements is the role of an integrated team that works together with some shared knowledge, but really always in the best interest of the patient. So I think there's a first poll slide.
There is.
Here.
Here we go.
There we go. So I'll give you a few seconds to participate and answer the question, and then the summary will show for us afterwards. And the question relates to, was there a comprehensive oral dental exam completed prior to cancer therapy?
Great, our answers are coming in. We're about a little over 50%. We'll give it another couple of seconds.
Great.
Okay, I'm going to end the polling in 5, 4, 3, 2, 1. And I will share the results.
Yeah, that's very interesting.
Wow.
So 80% of participants had a dental exam prior to their treatment. And that's actually higher than I would have expected. So that is really good to see. Okay, so next slide. So what we're going to focus on is not the acute complications, which are actually everyone that's a survivor experienced, but the oncologists and the cancer center are more familiar and more attentive often to the acute oral needs during treatment because they are so symptomatic potentially and really essentially universal. The chronic complications is what we're talking about in the issue related to survivorship. And these involve all of the head and neck tissues directly. Let me see if I can get my arrow going. So lining of the mouth, of the tissue in the mouth can be damaged, leading to scarring and sensitivity. Saliva gland dysfunction may be one of the driving long-term complications. And in saliva, it's not just how much, it's also the quantity or often the thickness or viscosity of the secretion. There may be sensory changes that follow, and sometimes indefinitely, that include change in taste function and in oral or tissue pain involving where the radiation fields were in particular, but also related to chemotherapy. The teeth can be damaged. The gum tissues may be affected. Soft tissue or bone may also be damaged, leading to necrosis. And we'll talk a little bit more about soft tissue damage and exposure of bone and what that might mean. Scar tissues may develop in muscles or around soft tissues that limit movement and function, such as limited jaw opening. The oral condition, including saliva, but also the health of the soft tissue affects dentures, fit, and function if those are present. And all of the complications can affect the functions of the mouth and the oral cavity, those like speech, eating, swallowing, and ultimately dental disease and or the surgery can lead to changes in appearance. So there is a long list of chronic complications. The next question is what might be the frequency or the impact of these kinds of side effects. So this was a survey that was based on a survey tool that was actually developed for head and neck and oral complications in cancer patients, where I'm showing the outcome of moderate or severe symptoms, so symptoms that will impact the individual. And you can see the frequency, about 2/3 had dry mouth, difficulty chewing or swallowing in 50%. This is in survivors. Difficulty sleeping, that may relate to function and saliva texture and quality. And you can see thick saliva was present in 1/3 of patients. Taste change persisted in 1/3 of patients. Sensitivity of the lining of the mouth, mucosa was in about 40%. And then new or increased dental complications occurred in approximately 20% of patients. In this review, there was, I think, a median period of approximately 9 to 12 months following cancer treatment. And certainly some of these issues, including the dental complications, may be more identified later than that. So why does all this matter when you're trying to treat and cure someone from cancer? And that is because the toxicities themselves, especially the acute ones, can affect therapy and how, if treatment is changed or interrupted. But both the acute and the chronic complications affect the cost of care, affect quality of life during and following treatment. We'll ask a little bit more about the medical and dental insurance concerns that are a reality in the United States and in fact in Canada as well. The frequency and severity of complications are often underreported. And in a survey that we also did, this underreporting was based upon the individual, like the person who had the cancers, assessing the focus of the provider. So if you were an oncologist, they may not talk about the tooth problems that they had spontaneously, but if asked about that, then that may be information that becomes reported. So it may be underreported by the patient. It may not be addressed by the providers to the same degree. And then that leads to an under-evaluation and under-treatment if you don't recognize the problems. And part of it is that people with the problems should be informing all of their healthcare providers of their status. The toxicities of radiation therapy for head and neck cancer are mostly related to oral function. And in this survey, it was 80%. Reactions of normal tissues may be dose limiting, and people that are having active treatment may recognize mucositis and the problems that that creates. And individuals have very varied levels of severity and duration of the complications during therapy, and similarly with recovery following treatment. So there's this famous bell-shaped curve described where a few have little in the way of complications, a few have severe complications, and most people fall somewhere in between. So what I was going to do is just talk a little bit now about the individual complications, and then minimally about treatment, and then get back to the patient experience, which Carolyn is going to present. So saliva function is one of the driving acute, but also long-term complications. And as I mentioned, it's not just how much do you have, it's the quality of it. So in some cases, and in fact, often during cancer therapy, that thick saliva becomes more of a problem than actually not having any significant volume, meaning having a dry mouth. So sometimes the texture is a bigger issue. The impact is on function and on dental health, especially in the long term. And the treatments that are possible are, one, to stimulate any residual salivary gland function, so you produce your own saliva. That's not as frequently considered by providers because they're not very aware in the dental community of the medications that may stimulate function. Mostly people are given palliative agents like mouth rinses and maybe lozenges. And in my view, that should be reserved for people who don't have function that remains that we can stimulate. And of course, stimulated saliva then gives you your own secretion, which is both more convenient, but more all-encompassing in a number of functions. So I'm going to show you a couple clinical pictures, some of which may be useful for the individuals on this call, because you can recognize some of these yourself. So the first thing is on the side where the teeth look great, where I just moved the arrow, the tissue is dry, it's sort of glossy. It's same on the other side where the teeth are already damaged. But people don't recognize that the whiteness towards the gum line of these teeth, where it's a little brighter white, is actually the initial stages of demineralization of tooth structure. So the whiter areas along the gum margin and at the tips of the cusps of teeth are the higher risk sites in dry mouth patients. When it's whiter, we can almost always re-harden that structure, meaning avoid the progressive damage to teeth, and in fact, in many cases, avoid any fillings or restorations because the anatomy remains intact. Once the mineral is further lost, as the slide with the arrow on it now, then the structure breaks down. And once we have a defect in the structure, we have to replace that to create a sound surface. But the problem is, and you can see it on the slide with the stained teeth, the structure is whiter beyond that brown edge and then gets a little more normal, but that's demineralized too. So in other words, the destruction is over a broad area and it's hard to manage by doing the restorations, but it's much better to prevent. So prevention we'll talk about in just a bit, but that's sort of the dental tooth issues. Another example of common complications are thrush or a yeast infection in the mouth. The risk factors to a large degree are dry mouth. So again, if we can treat that, you might have less of the yeast infection, but these are examples of white patches along the sides of the tongue. This case is more symptomatic because it's inflamed with the red component, but little white spots that are adherent are commonly candidiasis in a dry mouth patient. Subtle on this cheek, and I think you can see the arrow, but if we take another view of the roof of the mouth, that reddish area, often with sensitivity or taste change, may be reflecting a yeast infection, which is an ongoing risk in a dry mouth person. Other long-term complications are shown in the top two photos of limited opening or trismus, and that limited opening is initially often related to how severe the inflammation in the lining of the mouth is, but later the tissue can become scarred with healing, and that fibrosis or scarring is a long-term complication that makes challenging diet, makes challenging receiving dental care and maintaining oral hygiene. And you can see that on this individual, the fibrosis was pretty significant. And so that person's opening about a quarter of normal, which is a challenge for all of those issues. One of the most concerning complications in head and neck cancer radiation therapy patients is bone necrosis or soft tissue necrosis. And this is something that you might be able to identify early on your own and report that to your physician or dentist. And the commonest sites are at the back of the jaw where there's more radiation and there's poorer blood supply. So you can see in this photo on our left that there is an area that looks fairly superficial. That's exposed bone. And that may be at this point not associated with much pain, but can progress to a broader necrosis that really can damage function and be a major challenge to manage. So early recognition is sometimes the individual, you can feel some roughness with your tongue, and it's often in an area, this is on the inside of the lower molar towards the back, which isn't easily visible unless you're looking for it like a dental evaluation would include. So this may not be identified in, say, the cancer center. You might identify it as an individual. Here's another example right beside that of a small area of bone exposure Again, it's a little rough. It's maybe a little sensitive. In this case, sometimes there's no real discomfort, but those are the times, first of all, we want to prevent that, but if it occurs, we want to find it early. So these are things that survivors of the treatment can look for themselves. So getting back to a little bit about cavity prevention, it involves all aspects of this, and I'm going to actually start at the bottom of this slide, where if we can address salivary gland function to begin with, the risk of dental damage is minimal and reduced. But if we can't address the saliva to have a normal production of saliva, then we have to deal with the issues that may increase risk of cavities in the first place. So the bacteria in your mouth that may accumulate more in a dry mouth, be harder to clean off. We may use a mouth rinse, and people are probably pretty familiar with this, chlorhexidine, which is a mouthwash that has an antibacterial effect that can overcome some of the loss of antimicrobial effect from normal saliva. We can deal with the mineral in teeth, which we do with fluoride, but also the other minerals include calcium and phosphates, and we have to deal with that. And we can emphasize oral hygiene and diet maintenance to help reduce cavity risk. For the scarring or fibrosis, then that limited jaw opening is termed trismus. That goes right back to the beginning of treatment planning. It goes back to jaw opening exercises with assistance or active devices during therapy or following if it starts to develop. And then there's some medications that may be used to help reduce that risk, and some newer therapies called low-level laser or photobiomodulation that may reduce the scarring and improve function. This may also have a role in lymphedema, which is classically more of a radiation effect, although in combination with surgery, it may affect the lymphatic drainage in the neck. And this soft tissue fluid that builds up can then lead to, over time, maturation and more trismus or scarring in the tissue. So there are therapies for each of these as they develop. And if we're going back to just dental care for survivors who may attend their dental office, the non-surgical treatment is without risk. In fact, the maintenance of good dental health reduces the risk of ever needing surgical intervention and therefore of jaw necrosis. And so that's an important, maybe more frequent schedule of visits that are necessary in survivors. But if bone exposure occurs, or if treatment needs to be done within the radiated area of the jaw, then there is a risk of non-healing, again, bone necrosis. Those episodes or events that may lead to that should be planned by the dentist with either the oncology team. Certainly radiation therapy can always give a pretty definitive outline of where the radiation went, so you can understand if that treatment may be in an area at risk as far as healing goes. And we try other ways to manage the problem than surgery if possible. This is best done in a coordination between the dental team, maybe a dental specialist, and also the oncology providers. So dental care, non-surgical, is not a risk procedure, but any surgery can be. Just a couple of comments that I think are worth discussing for people who survive a cancer. Any new discomfort in an adjacent area or in the area of where the treatment was conducted is going to raise the anxiety that this is something to do with the cancer, either recurrence or progression. And so the pain experience may be that much greater. So when someone, say, has jaw pain, we need to make a diagnosis of the potential cause. And if it's dental, we need to treat the tooth problem. But when it's beyond that, we may need to treat the symptom. And that may require some people with more interest in facial pain rather than just the routine dental providers. And there are numbers of ways to manage this with different medications and different therapies. Some people who have jaw discomfort or dysfunction may have, in essence, a TMJ presentation due to other complications, due to maybe surgical fibrosis, jaw movement changes, or in fact, more stress that leads to more clenching. And so we would manage those as we would a TMJ if that's the symptom. So rather than just loading up on, say, direct pain relievers alone, we may direct therapy like we would for a standard TMJ complaint. But basically, we need to treat a specific cause and rule out any other causes and then manage the symptom as best we can. Just a couple other comments that in addition to oral management of the tissue changes, there may be dietary changes that may supplement or be important in maintenance of health and function afterwards. So if there's a loss of appetite, you may change the diet. We may also have medical approaches for management of that and taste change or taste loss. But there are dietary changes that may be helpful that people can do at home, or that people in dietary nutrition, particularly at the Cancer Center, can guide and make some suggestions for doing this. Mucositis is the sensitivity in the lining of the mouth, and obviously spicy or very abrasive foods may be problematic. If there's a dry mouth, the diet may become more liquid and soft, but also, again, as I mentioned, where we can, we will stimulate and replace saliva functions if we can stimulate it adequately. Trismus and difficulty swallowing due to some fibrosis or even dry mouth may lead to a change in diet, such as soft foods and smaller bites. And then the cavity risk or dental caries involves reducing the frequency of sugars in the diet and maybe focusing those around meal times. And interestingly, brushing teeth before you eat to remove the bacteria that may utilize the sugars that are in the normal diet is actually beneficial. So there are dietary interventions as well. And I already mentioned this, but any new symptom can increase anxiety with respect to, is this a new or a recurrent cancer? And the relative risk of cancers in someone who's already had one is clearly higher, and it's estimated to be about a 9 times or 9-fold increase rate. In this setting, though, of previous cancer treatment, it's harder to detect because there's tissue changes that are a consequence of the radiation itself, maybe yeast infections, maybe surgical anatomical changes and some scarring that occurs after. That means that the oncologist may be one of the key people, as will people with more experience in head and neck cancer care, just to be part of the examination, because it can be harder to detect that abnormality when the tissues are already changed due to past treatment. There may be some things that can be utilized that may help in that clinical detection. And the other thing is that there are a number of oral conditions that might be pre-malignant, and in someone who's already had a malignancy, it's possible that that was represented one of the risk factors for the disease initially. So we try to manage those mucosal changes a little more attentively, and that part of the management that is probably the most important is regular follow-ups so that we can see if things are changing, leading to diagnosis. Amongst the other things that should be done is the cessation of alcohol use. In studies, this is the International Agency for Research on Cancer data from a few years ago, but you can see that stopping alcohol use takes longer to really see a statistical difference in recurrence rates. So if people were heavy alcohol users, we really don't see a statistical change for up to about 20 years. Stopping tobacco use has a much more rapid potential beneficial reduced risk of recurrence or new cancers. And you can see in their studies, 1 to 2 years of discontinuation resulted in about a 50% reduction. And by the time you're 20 years out, you're back to baseline. And the last note on here, which is all abbreviations, so I'm going to talk about it, is human papillomavirus, which is the main cause of the cancers at the back of the tongue and in the throat of the oral pharynx. Not as common in the oral cavity itself, but certainly the driving primary cause of the current base of tongue and oral pharyngeal cancers that we're seeing. And the good news is those tend to respond better to treatment. So following cancer treatment and with the oral evaluation and the dental evaluation, a thorough oral exam along with head and neck exam is necessary. The dentist and the dental providers should have an understanding, at least in general terms, if not more specifically, of the therapy that was given, the status of the condition. We should be, as oral providers, reinforcing tobacco and alcohol cessation. We should know about the risk of bone necrosis based on the radiation fields. And actually, we really need to know as general providers in the community when things require more expertise and when to consult and when to refer. And so in last statements is the mouth is really part of the body. The healthcare system separates it out. That may create some other issues, such as the insurance and cost of care related issues. And I think there was one survey that I might have, or poll question that I think I went a little too fast and passed over, but maybe we want to do that now. So this will be question 2. There we go. So the question is about what side effects impact your quality of life after treatment, and you can pick any or all of these. So this question will take you a little more time to answer.
Okay.
Yeah, those numbers coming in.
Yeah. We'll shut it down in about 5 seconds. Looks like we've
Okay.
leveled off. 5, 4, 3, 2, and 1. We'll end it there. And here are the results.
Yeah, so pretty much like that one survey that I showed, which is dry mouth is the driver. And it's the driver of a lot of other symptoms, including difficulty swallowing and sleeping. So Carolyn will address some of these as a survivor, but thank you for those responses. So,
Bill, that's
sorry.
outstanding. Why don't we, as we make the transition to hear Carolyn's journey, you know, it's become obvious. This is obviously a very important topic to many who have gone through this treatment, and I'll just give the disclaimer. In the amount of questions coming in, these are all outstanding questions. In reality, we probably won't be able to get to all of them, so I'm going to try and group them as best I can into certain themes. And I was thinking we could address maybe 1 or 2 questions now, and then go into the discussion with Carolyn, listen to her journey, and then the remaining time we can spend on the rest of the questions for the amount of time we have remaining. So based on your survey, as well as what a lot of the questions centered around is on saliva production and the impact that has on quality of life. So, you know, maybe we can start with, you know, I think it was one question was posed on how these side effects are different for different people. And, you know, I think a lot of that depends on the dose of therapy that's given and where it's given. So cancer in the mouth, if you need higher dose there, may impact some of those things more than cancer in other parts of the throat. But what is it that you would tell people, you know, after therapy to try and optimize their day-to-day saliva production, you know, and people who have kind of mild to moderate issues with it, Joel?
Yeah, well, basically, your own saliva is better than any artificial thing that we can give you for a bunch of reasons, health protection and convenience. So if there's residual saliva function, which is easy to measure, and actually people can usually tell you, and you can tell by exam if there is some as opposed to none, then there are medications that are systemic that you take by mouth that stimulate gland output, and that is comparable to normal saliva production. The issue is exactly what you said. Depending on how big the radiation fields were and where they went and the dose of the radiation, you may not have adequate saliva gland tissue that's functional, so we can't stimulate it. But most of the therapies, unless the tumor itself is in a central location, will favor less dosing to one side of, say, the face, which then leaves residual function. So the newer therapies also, which is intensity modulated radiation therapy, or IMRT, which is what is the standard for years now, results in a lower dose of radiation over a broader area, but usually there is residual function. So in other words, I think the first step is to stimulate residual function when it's there. If it isn't, and if it isn't sufficiently responsive, then we use the palliative rinses and agents that might coat, protect, hydrate, and improve lubrication, as well as the epithelial hydration, which is sometimes forgotten. So yeah, so that's, I think, the best approach.
I think one other question related to that came up in the chat box is related to any ongoing clinical trial. So stem cells, gene therapy within the glands that has been used. I know for people who are looking to see, are there any new alternatives out there? Anything you would direct them to?
There are a few things. The active trial that is at NIH, there is one center actually in the world that is looking at gene therapy in salivary gland dysfunction following radiation therapy. They're looking for people 5 years out. So in other words, no evidence of disease with residual gland function. And that is an NIH funded available study. These studies, including this one, is sort of a bit on hold due to COVID and air travel, but that will come back. That's the one study that's looking at something which could be really remarkable by creating new gland function that doesn't exist at baseline. There are some other therapies, including photobiomodulation, which I mentioned earlier, which is low-level laser, that may provide some increased function. And the reason I say may is the main studies and the main use of the low-level laser in cancer therapy in the head and neck has been in reducing mucositis and speeding wound healing. Concurrent with that, there's some correlative evidence that there has been saliva production increase in some patients. So that's a possibility. It needs to be better defined. The therapy is available because it's a light device. The other newest therapy is the gene therapy that you mentioned. That is headquartered at NIH, and you can find out on that about that study from cancer.gov.
Well, thank you so much, Joel. There obviously are a lot more questions still coming in, and we'll continue to compile a list of these. And then afterwards, even if we don't have time to cover all of them during this live session, we can follow up with both of our panelists as well as our other planning committee members and try and disseminate some of the answers to these to hopefully get your questions addressed. One, as we move over to our next speaker, Carolyn, one question that was mentioned is, does it make a difference what kind of a dentist you work with? And I would say absolutely. It is very important to have a dentist and an oral medicine professional who is a lot of experience with patients who have head and neck cancer and radiation side effects and surgical side effects. And not only to address things that come up, but to really be preventative in many means to try and prevent a lot of the more catastrophic complications from happening. And so I can't emphasize that enough. For almost all of our new head and neck cancer patients, we'll have them assessed by by our dental team. If they have a local dentist that they're comfortable with, who is comfortable with this sort of thing, we'll get them involved with them as well. So I'd love to transition it now over to Carolyn Dee. Thank you so much for joining us, and really excited to hear about your journey and then how you work to optimize your oral health now being a couple years out from your therapy.
Thank you. It's an honor to join both Dr. Epstein and Dr. Moore. Yes, Mike, we are friends. And he was right. Early in 2018, my tongue was hurting and I was looking for a cut and found a lump. That same day I was in my dentist's chair and she walked me over to an oral surgeon's, and 4 days later, we had a confirmation of a positive squamous carcinoma. And it was a shock, very much a shock, because 20 years ago I had advanced breast cancer. So I've been through this game. The recommendation of everybody was get it out now, no delays. My dentist called the oncologist in town, who also happened to be a friend, and we met. And within 1 week, I was sitting in Dr. Moore's office reviewing what my options were. And within 3 weeks, I was in surgery. And they replaced my tongue with my wrist, and spent a few days in the hospital, which was a great deal of fun. And I went through about 3 weeks of recuperation. And during that time, both my oncologist and my dentist were conferring on what my options might be. And they actually discussed pulling out all of my teeth because no operations on your jaw after radiation. And finally, they put together a radiation program, decided to go ahead with it. I had 7 weeks of radiation, 360 degrees. From the time I was diagnosed to the time they performed surgery, the tumor had actually done some branching, and my oncologist felt it was best to just do the whole thing and protect everything. It did kill my saliva glands. Dry mouth is probably the scourge of this disease, but after radiation, after surgery, it was about 6 months of feeling like I was swallowing glass every time I had to swallow something. I had to move to liquid medication for most of the medications I take. I did have thrush 9 or 10 times. Every time it would go away, it would come back. They finally sent me to an infectious disease specialist who said, "You're not treating it long enough. Let's expand the treatment, same medication, but longer." And after that visit, I've never had thrush again, which is a good thing. I've been on intermittent exchanges with gels, sprays, lozenges, everything for dry mouth. There is nothing that really makes it go away permanently. Always have water with you. In November of 2018, I was feeling overwhelmed by choking sensations and a large tongue, and Dr. Moore did go in and reduce my tongue, which helped a great deal. But so we took both out, and then we went through more rehabilitation, and rehab is a very important part of this. So you get a good physical therapist that will help you strengthen your tongue, strengthen your jaw. I can pretty much open my jaw, but I can't stick my tongue out anymore. And there are some people I'd really like to be able to do that too. After recovering from the radiation and surgery, I went back into the dentist, and she noticed that some of my teeth were starting to deteriorate. And since pulling was no longer an option, she decided to whittle down all of my teeth to what I call little nubs, and she capped every tooth in my mouth, which was a huge project under the conditions, but it needed to be done. And that has protected what is left of my own teeth. I've had no decay under the caps, which is really good. But again, it's using the chlorhexidrine, it's using mouthwashes, and there's really good mouthwashes and toothpaste that your dentist can recommend to you that fights the bacteria problem, because bacteria in a dry mouth is a very serious problem and very dangerous to your teeth. They put me on a 2-month cleaning schedule, so they're keeping an eye on it, as well as what I'm noticing. That has sort of wavered a little under COVID. There's been some time that I wasn't feeling most comfortable about having someone work in my mouth, but they're keeping an eye on it anyway. I was going in for 3 month checkups, like some of the notes I've seen. And in July, they graduated me to every 6 months, saying that I was doing very well and healthy. And an ironic post-note, I did tell Dr. Moore this earlier, last week, part of my tongue split on its own. And today the doctors looked at it and said, it's healing, it's forming new skin, it's great. So it's a journey that's tough. It is painful at times. To me, the very worst of it is the dry mouth, because I can't seem to get a handle on it. Of Dr. Epstein's list of impacts, I must be the test patient here. All of them qualify for me, except not much trouble sleeping, once I got out of bed, so I was sleeping sitting up. Following surgery, I could not lay down for about 6 months. And it's good to have something that will prop you up, make your breathing easier, your swallowing easier. I still have trouble swallowing. I probably always will. So I'm on predominantly a liquid diet. And while that sounds horrible, it happens to be something I like. And I'm making shakes and I make all my own protein soups. And I had lost a good deal of weight before surgery, but have maintained it since. And all of my blood work and everything comes out good. So liquid diets are not totally bad. But there's a couple of things that to me, and I mean, you all have touched on these things, but tissue reaction obviously does affect how you can be treated. Be absolutely open and honest with your doctor. Because I had had very advanced chemotherapy and radiation treatment for the breast cancer, there was a limit to what kind of treatment I could take. The chemo also had attacked my pancreas, which made me a diabetic. So not only is sugar bad for my teeth, sugar is now bad for everything. But the thing that got me through it, I guess to the most degree, is an amazing team of medical people, and that's my surgeon, my oncologist, and my dentist. And they all talk to each other constantly. They discuss things and then discuss it with me before they make the decision. But that was my team. And the other part of my team was my family. I'm one of 6 kids. As Dr. Burke can tell you, they were in the hospital every day, driving us all crazy. But they were my support. The most important part, I think, to me is attitude. And through all of this and everything that's gone along with it, I've never cried. I've never let it get me down. This is what it is. Let's get on with it. Let's figure out how to fight it, how to make it better. During this entire time, I was still a mayor of Truckee. And in that year, I missed 2 meetings. That's all. I would write notes to my vice mayor and say, ask this, do this. But I was there and I was engaged and I was doing what I cared about. And there were times it was tough, but I knew that was what was going to heal me by being engaged, being positive. I talk about this to anybody who wants to talk about it because I think the more education we get out there, it's the best thing we could do. I'd never even heard of this. And then one day I had it. And it was, how do you deal with this? What do you do now? And you really have to keep that positive attitude. It's okay to cry as long as you have somebody to get you up again. And I was afraid maybe I didn't have that person. I am a widow, so my husband also died of cancer. And go in with a very positive attitude and look for ways to make your life better and make others better. And help other patients, find people who will help you. Don't be afraid to ask questions. Don't be afraid to ask for help. And don't be afraid to ask your doctor, even if you think it's a stupid question. There is no stupid question. And we are all still learning about this. I'm almost 3 years into it. And I made some notes because I learned a lot of new things today. I know Dr. Epstein about that saliva stimulation. We have to talk.
We'll talk.
But there are new things every day. And that was kind of how I got through the breast cancer. I knew if I could buy 6 months, there'd be a new medication. I feel the same way now. I can survive this. I can deal with it. I can work with it. And there'll be something new coming down the road. So stay on top of the changes and stay close with your new friends. It's very important. And make sure they're communicating with them and you.
I will say, Carolyn, go ahead, sorry.
No, I just to say, I wish you all the very best. I know the journey can be challenging, but it's worth it. We're not done yet, so keep fighting.
I think it's absolutely true. I think whenever I talk to patients who are going through such a big operation and a challenging recovery, I typically mention that I go from surgeon to cheerleader overnight. Now, I think with Carolyn, she's the one that was getting my chin up off the ground when I would come dragging it around in the morning every time. It's just truly inspirational. All that you have been through and keep coming out on the other side of it, smiling and ready to keep moving on, each day living life to its fullest. So we're so grateful you came and shared your experience with us. A couple questions have come in. I certainly would love to get your thoughts on it, and also Joel's as well. A number of folks asked questions about fluoride, and everything from what is your daily regimen, kind of during treatment and after. Can you do too much? So people talked about getting fluoride and putting it on a night guard and leaving it in overnight. Are there any dangers to that? If you guys, maybe we'll start with you, Carolyn, how you've done it over the last couple of years and what you do currently, and then in the insight from Joel.
A lot of brushing, a lot of cleansing. I did learn that with the chlorhexidine, it can discolor your teeth. So instead of putting it on straight and scattering the days that I did it, I cut it and I put it in my water pick. So it was cut probably 4 parts water to 1 part chlorhexidine and sprayed it on that way. So I never had any discoloration, but it kept down the bacterial infections and helped us out. I've also been using things like biotin gels. I have lozenges. Most of them are sugar-free. There's a great variety of stuff out there. You need to kind of experiment with it and see what is the most comfortable for you. I mean, some burn, yes, the taste changes a great deal. Some of it burns, some of it works, some of it doesn't work for me in particular, but works for somebody else. Somebody told me to drink olive oil. Wasn't sure about that part, but there are lots of options. So find those, but be sure that you're keeping your mouth clean so that bacteria can't grow and do damage. And be in very close touch with your dentist. That really is going to be an important part of your life for the rest of your life. I mean, this isn't going away. So be sure that you keep that up. And then be like me. I always have a cup of water, a cup of tea, a cup of something that I can grab when it gets really bad. I've gone to liquid medications where I've needed to, and it's just an everyday progress. And you guys probably have better knowledge on what's out there on the market than I do, even though I research it.
One thing I always love about these sessions is the participants. I learn a ton from them, and I think they can also learn a lot from each other, because I'm seeing a ton of great answers being actually added into the chat box as well. So thank you all for doing that. Xylitol was mentioned, which I know has been recommended by many. Chlorhexidine typically is a prescription that you would write, but a lot of times it's in diluted, because the version that you get, again, can be fairly strong and can have a tendency to cause some discoloration as well. Dr. Epstein, as far as dangers of fluoride getting too much, and I know that was also brought up earlier, the suggestion of brushing before meals, if you could elaborate on that a little bit.
Yeah, okay, well, on the fluoride issues, some of that depends on how dry is the mouth as well. So in a number of cases with some residual function, we can reduce the intensity of the fluoride applications. And so there are some studies that have shown that reducing fluoride in the mouth guards, if you had carriers made, which is the best evidence of most effectiveness of fluoride, you may be able to do it once or twice a week rather than daily. And one of the things that can happen is if fluoride is intensely taken up into the tooth structure, just like potentially with a lot of excess fluoride in bones or other things that we do that make bones too hard, they become a little more brittle and less flexible. So you can lose enamel structures due to fractures. So you can use too much fluoride, but that in the cases of people that have no saliva function remaining, and if there's this demineralization process or tooth damage ongoing, then probably it still remains daily. And the most effective means that we know of application is with these custom-made mouth guards. The next approach can be just brushing on with the higher strength fluoride products, which are prescription, and replacing normal toothpaste, which may be more abrasive, which can cause structural damage, especially to soften tooth structure, with a less abrasive toothpaste or tooth gel. There's mention of xylitol, which is an interesting substituted sugar that actually kills cavity-producing bacteria. It's not that they don't use it and that they are less productive. They actually can be affected directly by xylitol itself, and that's in most sweeteners now. So you can look for artificial sweeteners in foods, for example, and mints or candies or products that might stimulate function just based on taste and presence in the mouth. If there's xylitol sweetened, that makes sense. Now you can overuse xylitol too and get a little bit of upper GI irritation or sensitivity, but that's pretty uncommon. But if it is, you just reduce how much you use. Chlorhexidine is an interesting product. It is prescription, as Mike said. There's two main forms of it in available commercially. One has alcohol in it, which tastes more like regular mouthwash, but they can stain teeth, but that's in a percentage of people. The other one is a water-based, and actually there was some manufacturing issues just in the last few months that will be reversed or managed. And because there isn't alcohol in that, that's less irritating or sensitive to the tissue. So if there's buildup of plaque bacteria that are causing gum and tooth damage, that's an appropriate product. And again, depending on the conditions.
Very good. As we're kind of getting close to the hour here, a couple of other points that came up that I think would apply to a lot of people. The issue that people run into with regards to getting insurance coverage of the pre-treatment evaluation. And then again, the more frequent assessment afterwards, because a lot of times plans may cover twice a year, but they don't cover some of the extra. Any tricks of the trade that you've used to allow for that to be covered?
Well, it depends on the insurance, and that's part of the issue. And, you know, the insurance world is potentially continually changing, you know, as governments look at health and disease, and, you know, the discussion that's ongoing even today at the Supreme Court. Depending on the environment and the insurance, pre-treatment dental assessment prior to head and neck cancer treatment can be billed or reimbursed to a patient through medical coverage as a medical visit because it's medically necessary. Now, as soon as a dentist does that, the insurance may right off the top say, well, no, it's dental. But in Medicare does allow that billing for that purpose specifically. But following treatment, people are more on their own. When I see people in hospitals following cancer therapy, we are allowed and capable and able to bill as though it's a medical visit, but we can't bill the medical visit for dental procedures. So in other words, if you need a filling, even post-treatment, potentially in most cases, if you need an extraction, that may not be an insured service on the medical side. And it's really this battle between who's covering what. And unfortunately, that's a hole in oncology care in particular, and maybe more specifically in head and neck, because many of the treatments can, under the conditions of previous cancer therapy, may lead to complications that need to be managed. So rationally, this should be more medically oriented than it is. But done in a private setting by a dentist, the first response by most insurers, if there is insurance, is to deny initially. The other real problem, though, is that most people, especially if you're over 65 and retired, you're not going to have a dental plan of any consequence if you have any at all. And so then the issues become, the relative cost benefit of prevention, which really is well proven, but a lot of times that doesn't occur on a regular basis, and there isn't a means to change it in the current system. But I think that might change. There is discussions along with healthcare reform, looking at incorporation at least of some aspects of these services in that setting. And maybe that's how it could start rather than comprehensive, but that, that's political, and we've just been through a lot of politics and that's going to probably continue. But it's something we should be pushing for.
I agree. It needs some sweeping reform. In my case, the biopsy was considered medical. So my oral surgeon was able to submit that. The post work was only covered up to the maximum of my benefit. And the cleaning, I have insurance through my company, and I get twice a year, and all the others I have to pay for it, even though they admit that this is due to a medical condition, not just everyday dental care. I talked to Medicare about it, and they said, yes, we understand this is surgical. It's very seriously medical, but we do not cover any dental at this point. And it is an expensive proposition to have all your teeth taken care of. So yes, I agree. That definitely needs to be on everybody's agenda, to start looking at how we can implement some reform in that field. It becomes critical in these cases because people are already dealing with challenges, physical, emotional, financial, and then putting this on top of it is really a capper. And if we could get some of them to recognize these as medical conditions rather than dental conditions, it would be a huge help, I think, to people.
Very good. Yeah. Thank you both so much. For me, it's been incredibly educational and inspirational. So I can't tell you how much we appreciate it. And we also appreciate, all the survivors and caregivers for calling in and being in attendance. As we kind of wrap up the session here, the one last, point that was brought up a couple of times in the chat box is, when do we start to worry about things, whether it's in the context of lichen planus or just as you're after treatment? I think when things are progressively getting worse and not better. So, whether it's lichen planus, you've had some white patches that have been followed and they start getting more sensitive, more painful. Certainly if they start bleeding or you start noticing any depth or texture to them, those are things that you want to have evaluated. Err on the side of caution. Certainly if it's progressing over a couple of weeks, you would want to have it seen. And worst case, it ends up hopefully being nothing. And you can go and be seen and they say, oh, this is nothing to worry about. But err on the side of caution, because the longer you wait, if it is turning into something more significant, you'd rather get it addressed sooner rather than later. So I just wanted to take a time to thank both Dr. Joel Epstein and Carolyn Dee for the session. It's certainly been great for me. Also wanted to thank the Head and Neck Cancer Alliance staff. Amanda, Eileen, Elizabeth, and Delane are fantastic. Thank you for your work on this. And thanks to JJ from the American Head and Neck Society, and also the other planning committee members, Carol Fakri, Nishant Agarwal, and David Cognetti. So thanks all of you for joining us. We will be having our next session on intimacy and head and neck cancer, likely in late January. We don't know the exact date yet, but we'll be in touch. As I mentioned, I'm sorry if we didn't get to your questions today. We will be compiling a list and we'll try and group them and answer them to the best of our ability and disseminate them back through the contact information we have for you. Thank you all for joining us. Really appreciate you taking the time.
My pleasure to be with you, Mike and Carolyn, and all the participants. And Carolyn, thanks for being a real light in this session.
Crazy lady. I just figure I'm not done. I got a freeway repaved. I did some other things. I'm not done yet.
Absolutely
I'm gonna
not.
keep fighting and have to, Now move to a new place and take over.
Yeah, good luck with the move. I'm excited for you.
Great.
All right, thanks everybody.
Thank you very much.
I'll go ahead and end it.
Bye.
Good night.